also a newsletter co-editor and communications chair. I'm going to introduce our next speaker, Dr. Martin Rosenthal. Dr. Rosenthal is an assistant professor of surgery with the Division of Trauma and Acute Care Surgery at the University of Florida College of Medicine. He is board certified in surgery and surgical critical care. Dr. Rosenthal earned his medical degree from Mercer University School of Medicine in Savannah, Georgia, and completed a general surgery residency and a fellowship in critical care medicine at UF. His postgraduate surgical training included nutrition fellowships at Louisville University and Oregon Health and Science University, as well as an abdominal wall reconstruction course. He has professional interests in nutrition and intracutaneous fistulas. Dr. Rosenthal serves as the chair of the Nutrition Committee at University of Florida and is a member of several professional and medical organizations, including ASPEN and the Society of Critical Care Medicine, and is a fellow of the American College of Surgeons. He has written numerous journal articles and textbook chapters and enjoys discussing his research on persistent inflammation, immunosuppression, catabolic syndrome, and how potential nutritional intervention could help decrease inflammation and promote anabolism. Please welcome Dr. Rosenthal.
Thank you very much for that introduction. Can everybody see my slides?
Yes.
Perfect. All righty. Well, let's get into the end of the presentations, and I'm going to talk a little bit about nutrition and what it means for the inflammatory process, as well as various supplements that we can use to promote anabolism. Todd set this talk up very nicely for me, so there's going to be a lot of maybe replay, but at the same time we can discuss different points. The learning objectives, you can see, are to discuss the evolution of inflammation into chronic critical illness and PICS. I do have a case presentation of COVID-19 that ended up with a PICS patient, so I think that'll be fun to kind of see the evolution in real time, and then discuss recent evidence. Is gold standard actually enough when we're actually trying to deliver nutritional therapies to these types of patients? Are they actually doing a good job? And we can discuss that. And then the last thing would be the anti-inflammatory nutrition and the roles that these different elements may have. Here are my disclosures. So here's the case report. It was a 22-year-old female, was admitted to my surgical ICU after she had a car accident. She was drinking and she was smoking marijuana. Ironically, there was 2 other people in the car, and they were all sharing the joint or whatever it was, and they all ended up COVID positive. But she actually suffered the brunt of the injury because she was unrestrained. She ended up getting a traumatic brain injury, what we call a grade 4 splenic laceration, which is on a scale of 1 to 5. So 4 is pretty bad. She had what we call a hemopneumothorax, which she had blood and air trapped outside of her lung. She had 7 rib fractures, a small liver injury, and then a sigmoid perforation with an adjacent traumatic left flank injury. And what that is that's a high mechanism, a lot of different angles coming at the abdominal cavity, and it's usually associated with a shear injury. So if you can think of a twisting motion, that ends up causing the flank hernia, and it usually comes right off that hip bone. And hers was on the left. And when you have that kind of mechanism where you're shearing the muscles off of the anterior iliac spine, ends up having a simultaneous bowel injury about 85% of the time. And then she was also found to be COVID-19 positive. She was intubated for respiratory distress prior to even getting to the hospital. In the trauma bay, she was unstable, meaning her blood pressure was less than 90. She was tachycardic, she was hypotensive, and she was FAST positive, meaning I take an ultrasound and I stick it on the abdominal cavity, and once I see that there's fluid in there, I have a source of bleeding, because any fluid in a hypotensive traumatic patient is deemed blood until proven otherwise. And on the emergent laparotomy, because we went straight to the operating room, I removed her spleen, I placed a chest tube for that hemopneumothorax, packing of the liver injury, which just means laparotomy pads around the liver to compress it so it stops bleeding. And then I took out her sigmoid colon that was perforated. and left her in what we call discontinuity, meaning it was a damage control operation. We put a temporary dressing on her belly, brought her back up to the ICU to start correcting any of her deranged physiology. Radiographs confirmed the injuries that we already discussed, as well as the bilateral diffuse patchy infiltrates, which is kind of the hallmark of COVID-19, or it could also be a pulmonary contusion. But with her having COVID and the rib fractures, at that point, we actually decided to treat her with ventilator strategies for virtually both. It's almost like an ARDS type picture. I consulted neurosurgery for the traumatic brain injury, and they said it was small. Her GCS, or Glasgow Coma Scale, was less than 8, meaning she wasn't really following commands. And an ICP monitor, the intracranial pressure monitor, was placed. It wasn't very high, and the opening pressure wasn't very high. So the strategies to actually help control any kind of elevated ICP was not warranted at that point. She returned to the operating room, hospital day 2. We ended up doing a diverting colostomy because of all the contamination in her abdomen. And she was still pretty sick at that point. Repaired the hernia very quickly, and then performed a sequential abdominal closure, closing the cavity, leaving the skin open. By hospital day 4, you could see that she actually went into septic shock. Now, was it a ramification of everything her body underwent during the operation? Was there a missed bowel injury somewhere? Was it just COVID-19? There was a lot of different things going on for this patient, and we ended up having to get a CT scan. We found a little pelvic fluid collection. We stuck a drain in it. It looked more serosanguinous, but bacteria did grow out of it, so it was deemed an abscess at that point. And then she very quickly started deteriorating from a pulmonary standpoint. She was on very aggressive ventilatory pressures and having to try and do things that are not normal for just any other patient. She was in what we call bi-level, which means the ventilator was trying to recruit some of the lung tissue so that we can oxygenate her at the expense of having high CO2s. And this was starting to fail. We considered maybe doing an oscillator, but it wasn't warranted because we have ECMO at our hospital, and the TCB surgeons, or the thoracic surgeons, came over and cannulated her for ECMO, but ultimately she ended up improving and did not need to go on an ECMO run at that point. Hospital day 6, she was stable on her pressors. She had steroids for adrenal insufficiency, and I started doing some trickle tube feeds at that point. Her pressure requirements were a little bit too high for me to go straight to goal. Steroids mean nothing to me as far as when I should or should not start any enteral nutrition, but we were trying to start feeding the gut. I felt like it was safe at this point to start doing trickles, nothing more than about 10, 20 cc's. And hospital day 7, we started supplemental parenteral nutrition because we weren't going anywhere, and she was still on the pressors. And we have a protocol that says that if you're over a certain pressure requirement, going to gold tube feeds is not appropriate. So by hospital day 10, she was actually off all of her pressors, started to increase at that point to goal. And we started weaning some of the calories in our supplemental parenteral nutrition. But then on day 11, when we were actually probably over 60, 70% of her goals, she started having abdominal distension. It looked like she was having feeding intolerance. So we got a KUB, confirmed that she had an ileus, and we had to back off of our tube feeds, and we held with our supplemental parenteral nutrition. Hospital day 16, she had return of bowel function through her ostomy. She was having a form of stools, and there's gas in the bag. We advanced our tube feeds, and we were able to wean off the supplemental parenteral nutrition. So this patient, as you can imagine, hospital day 16, we're getting into the throes of chronic critical illness. There's a lot of different definitions for chronic critical illness, but ours is anything over 14 days with ongoing organ dysfunction, and she definitely hit those markers. And the early concepts of multiple organ failure, you could see here that they would go into this kind of SIRS response, and then you would think that when they go up in the initial wave, that there was some sort of compensatory mechanism to bring people back to homeostasis. This line right here is homeostasis. And in moderate surge response or systemic inflammatory response, and then you have this CARS response. And people thought that the CARS response was this compensatory mechanism to bring people back to homeostasis. But we now know through different studies, different ways of looking at immunologic features, that there's actually both going on simultaneously. And here's the things that we use for surge criteria: temperature over 38, so you have a fever, or you're hypothermic, less than 36, heart rate over 90, respiratory rate over 20. These are all different physiologic parameters that shows that there's a systemic inflammatory response going on. And this compensatory mechanism wasn't really actually compensatory, because it's is it going to be a Th1 response, or is it going to be a Th2 response? It's usually a combination of both. Initially, a Th1 moves into Th2, but is this an adaptive immune response? And sometimes it's actually maladaptive. You become almost immunosuppressed from this, and you could see that during this immunosuppressed state, you can have the consequences of increased nosocomial infections. And so this early concept actually now looks more like this. And so this is what we've bored out in different studies, studying immune systems, studying different cytokines, and we see that these responses happen all together. And so this paradigm, you know, all the way over here, you have sepsis. It could be pancreatitis. It could be a bad burn, polytrauma. It could be any kind of pathologic state that elicits an inflammatory response. But you have SIRS and CARS happening simultaneously. Here's our 14-day break right in the middle, and that's what we have used as our chronic critical illness state. And they have ongoing organ dysfunction, and they have this persistent inflammation. They have progressive immunosuppression, and they have this catabolism that's refractory to nutrients. And if you have that persisting throughout, then you end up going into PICS. Thankfully, not too many people actually go into chronic critical illness, but sepsis seems to be one of the biggest culprits of producing this new phenotypic presentation. This is a little bit more complex, but I just wanted to show you that this is what we use for our different grants. This was used to actually show and promote to the NIH to get a P50 grant, and that's what one of my mentors, Fred Moore, used in order to show how people can still persist with the inflammation, the catabolism, immunosuppression, and they generate this PICS phenomenon. And it's very hard to treat them out of it, especially with the advancing age, unfortunately. And I'll show you some studies, they just don't do well. This was a study that we did. I went back and looked at 56 chronic critical illness patients, matched them to 112, so doubled the cohort of the CCI folks just to increase the power. And we matched them for Charlson Comorbidity Index, just so that they all had the same well, not the same comorbidities, but they had the same index score, meaning that we weren't selecting any sicker or any healthier folks. We matched them for age, sex, and how sick they were coming into the hospital. In this retrospective review of our database, I would say 75% of patients reached goal calories by the end of the month, which was my study period. 75% is not, you know, 100, but 75% is actually pretty good. And if you look at the literature across the board at any major academic institution, we do a poor job of delivering calories. There's studies out there that range from 40 to 60% for hospital stays in patients, and I think that we can always do better. I actually went ahead and I excluded the first week of everybody, every patient's hospital stay, and looked at the last 3 weeks of their calories. And we actually reached 88% during those last 3 weeks, which is far better than 75. And the reason being that if you think about it, I'm a trauma surgeon. So in the first part of their hospital stay, much like our 22-year-old female in the case presentation, they're going back and forth to the operating room. They may be left in discontinuity. They have damage control operations going on, where if it's sepsis, we might be having to do surgical source control. And if they're truly septic and on pressors, this means that they're not getting nutrients. So that first week is a little bit of a misnomer because it's very hard to get meaningful nutrition into some of these patients. A little bit easier when you're dealing with a MICU patient population, but as you can see, the numbers don't lie. The last 3 weeks of their hospital stays, we were doing pretty good. The chronic critical ill folks had non-home discharges. What does that mean? Those are the folks that are going to long-term acute care facilities. They're going to nursing homes. They're not going home. They have to go somewhere else as a transition of care versus the RAP cohort or the rapid recovery. Sorry for not telling you. So our RAP is our rapid recovery. They return to homeostasis before that 14-day mark. And a third of them are going to non-home. So those folks are actually going either home 2/3 of the time, or they're going to, a rehab facility so they can get a little bit stronger before they transition to home care. You can look at the survival. So 67% of the patients with chronic critical ill state survived. A third of those folks are dying at a year. That is an inordinate amount of people, especially after you get them through their initial disease state, whether it's sepsis, septic shock, or severe sepsis, trauma, whatever have you. They're dying at an alarming rate versus only 8% died in the rapid recovery. And so what I'm going to show you next is a bunch of biomarkers. Like I said, PICS syndrome is the persistent inflammatory immunosuppressed catabolic syndrome. And so these are all the inflammatory markers that we were looking at. Here's IL-6, IL-8. Your CCI patients are this red or reddish pink color, and the rapid recovery folks, they return to baseline, or their inflammatory biomarkers aren't nearly as elevated as those with chronic critical illness that go into PICS. Here's the immunosuppression. We looked at absolute lymphocyte count and what we call SPDL1, or the soluble programmed death ligand marker of immunosuppression. And as you can see, the rapid recovery folks had much higher lymphocyte counts, meaning they weren't quite as immunosuppressed than the chronic critical ill folks. And the marker SPDL1 was higher in chronic critical ill folks and much lower in the rapid recovery, again showing that they were immunosuppressed. And then catabolism and stress metabolism, I kind of linked those together, but we have glucagon-like peptide was higher in the CCI folks, meaning they had a lot more insulin resistance. And then we have urinary 3-methylhistidine, where when you look at muscle catabolism, muscle breakdown, your muscles will release this 3-methylhistidine, and it's cleared by the kidneys, and so you can use it as a rudimentary biomarker of what is going on with your lean protein muscle mass. So why does this actually matter? Does anybody care about this? Is it just me, up here trying to figure things out? Well, looking at the body of literature surrounding chronic critical illness, 5 to 7% of all patients admitted to any ICU develop chronic critical illness. In a surgical patient population, trauma, it's about 20%, as we saw with the last publication. And after sepsis, about 50% of patients can develop CCI. More than 380,000 cases with 107,000 in-hospital deaths. Patients that develop CCI devour 30% of all ICU resources. That's incredible. That's largely taxing on the providers as well as the hospital systems. And as you can see, overwhelmingly, it's an expensive process, $26 billion to healthcare expenses. This is an interesting study that Stephen Anton, who's a member of our Aging Institute at UF, he went back and looked at some of these patients, and he wanted to look at their 1-year survival, quality of health, the short physical performance, mobility monitoring, and something called the Zubrod score, and I'll show you a slide about that. But essentially what ends up happening is it's not too hard to imagine, after I told you that CCI are consuming costs, they are not doing well from a physiologic standpoint, as well as these are the frail individuals in the ICUs. But here you can see that the short physical performance, even after they're out of the hospital, 6 months later down the road, you could see that this SBP score, they're not getting back or recovering to their normal baseline by any means. They're not able to even care for themselves oftentimes. Here's that Zubrod score. So 0 means that they're fully able to take care of themselves. They're functional. That's usually baseline is what we call. 5 is dead. And then you can see the different numbers 1 through 4 in the middle. This is a golf score. You know, you want the lowest score you could possibly get if you were to use this as one of your performance scores. And here you could see that the chronic critical illness, that top line, they're averaging out somewhere between 3.5 and 4. Going back to that other slide, look at 4. 4 is completely disabled, cannot carry on any self-care, totally confined to a bed or chair. That is an amazing, if there's anything you take away from this talk, that is an alarming and scary slide right there, because we need to figure out how are we going to get these CCI folks back to some sort of recovery. And this shows that we're not. Even at 12 months, we're not. Here's the survival curve for CCI. And again, this was all comers that we looked at in our P50 study. So about 2/3 are alive, 1/3 dies at a year. And so again, we're just showing that this truly matters, this new phenotype that's popping up, because we're doing a really good job of keeping people alive in the ICUs. You know, advancements in technology, advancements across the board as far as delivering care, using bundles, everything that you can think of as far as ICU care goes, we can keep people alive. But are we doing that only for them to die down the road later on? And I think some of this literature certainly speaks to that. So what do we do? How are we going to actually help promote recovery and get these patients anabolic instead of catabolic? Are we going to be able to, you know, feed them out of their crisis? I don't think so. I think that we're going to have to look for almost a holistic approach to treating this disease process. But there are certain nutritional supplements that we might be able to utilize. And so since about 2012, we came out with a new meta-analysis looking at omega-3 fatty acids. We included 49 studies, roughly 3,600 patients. And from that, we see that when we use omega-3 fatty acids, we can actually lower in-hospital infection rates, so 40% lower. Sepsis decreases, length of stays decreases, and that's incredible when you're talking about a chronic critically ill folk who's there for, you know, a month. Is saving 2 days really that important? I would say yes, but you know, it's not going to be lost. And if we can help use some of these omega-3 fatty acids to decrease the amount of inflammation in these patients, maybe they won't reach the CCI part and fall into that rapid recovery cohort, and they're out of the hospital in 14 days. And then in that case, you know, 12 versus 14 days, that is a considerable amount of time. And then mortality was reduced, but it wasn't statistically significant. There's different publications out there as well from expert consensus statements, lipid use in hospitalized adult patients, and essentially I want to share a couple of them with you. So there is sufficient evidence from this expert panel that suggested that there is significant scientific evidence to justify fish oil containing intravenous lipid emulsions as part of PN in both your surgical cohort as well as your critically ill non-surgical cohort. In high-risk critically ill patients, sepsis, ARDS, you know, even PICS, I had to throw that in there. We recommend including fish oil containing intravenous lipid emulsions as part of your PN in the first week. And as you know, that catabolism is driven by this inflammatory response. It seems reasonable to use omega-3 fatty acids to help resolve inflammation. And part of this inflammation resolution is a new area of considerable interest, because the lipid byproduct of omega-3 fatty acids produces these SPMs, or specialized pro-resolvin mediators. And this guy in the top corner, Charles Sirhan, came up with this discovery right around the late 80s, beginning of the 90s, and he wanted to start looking at the inflammatory process as an active, not passive resolution. Because he said, man, we know a lot about SIRS, we know a lot about sepsis, we know a lot about inflammation. And if nature holds true that there's a yin and a yang, then if there's something that turns on inflammation, there's got to be something that turns it off. And so he started looking for these pro-resolving mediators, and he had no idea what he was going to find, but he stumbled upon these lipoxins. When you add aspirin, it stimulates these lipoxins, which are going to be lipid byproducts that help decrease inflammation. And then he ended up discovering resolvins, protectins, and merisins. Protectins used to be called neuroprotectins because it was largely felt that the nervous system or the nerve tissue had a higher concentration of it. Resolvins are a huge pro-inflammatory resolvers, and that's where he got that name from. And merisins come from macrophages. So ultimately, Charlie Serhan said that this is an active process, and you had cessation of leukocytic infiltration. They decreased diapedesis, or the crossing over out of capillaries. You had counter-regulation of pro-inflammatory mediators, decreased in inflammatory cytokines. You had increase of apoptic neutrophils, and now we even see that with higher concentrations of SPMs. You have increased clearance of bacteria, yeast, even certain viruses, and you have decreased cellular debris. So the resolution of inflammation is now held to be an active process. They reported that the endogenous omega-3 DPA is converted during inflammation resolution into these omega-3 byproducts. So it's one of the coolest things that we have in our nutrition world, that we can actually affect or immunomodulate some of the active processes of inflammation. As I said, there's 3 different classes, and it helps to resolve inflammation, but could this potentially be the actual bioactive component of fish oil? Or is fish oil in and by itself its own anti-inflammatory properties? You know, there's that study that came out of the Inuit Eskimos saying that, well, they didn't have the heart disease that the rest of the world had. So maybe there's something going on in their diet and why they don't have the cardiovascular risk that other countries had. So they did an epidemiologic study, and they looked and they said, well, it's got to be the fish that they're eating. They eat so much fish and the omega-3 fatty acids that, you know, before the turn of the century, they were actually recommending that we use high doses of fish oil. I remember my parents taking fish oil by the bottle when I was growing up, and then right around 2015, several meta-analyses came out that suggested that, well, there's no harm in fish oil, but maybe the benefit wasn't quite clear. So it kind of fell out of favor, but we still use fish oil, and I still think it's a good nutrient to have, especially if you're inflamed in an inflamed state. Excuse me. I wanted to share this study with you. So Orr and Ron Tompkins and Charlie Serhan, they all came up with this kind of post hoc analysis of this multi-center, huge NIH-funded glue grant study that was looking at inflammation. They looked at burn and trauma patients, and they started to characterize what inflammation looked at. They looked at all these different cytokines, and they were trying to figure things out, but they did a post hoc analysis of 96 patients, complicated versus uncomplicated, meaning they recovered and got out of the hospital or they had complications. And when all the genes were combined into scores from the uncomplicated versus, they actually had different resolvin scores as well as the leukotriene scores. And I'll show you that here. What was in the numerator for each of these, you know, obviously would be whatever promotes the production of resolvins. So the receptors, the enzymes that they needed to serve as catalysts of breaking down omega-3 fatty acids into resolvins. And then on the denominator were things that would break down resolvins. And so they would come up with these genetic scores for both resolvins and leukotrienes. And here's what they found. So the top one, this is the resolvin score in the top corner. The blue line is the uncomplicated patients, so they had higher resolvin scores, and the red line is the complicated, so they had lower resolvin scores. And that makes sense. You know, if you're going to have an uncomplicated clinical course, you should have more resolvins circulating in your system, and hopefully you can use that and make that have a clinical impact, which would be to get out of the hospital and have an uncomplicated trajectory. Subsequently, the leukotriene score, you could see the red or the complicated patients had higher inflammatory scores or leukotriene scores when compared to the uncomplicated folks. And that makes really good, perfect sense to me. The unfortunate thing is I went back and redid that study with the patient population that I looked at, those 56 CCI patients that we published earlier. And I went back and, again, the CCI patients had higher leukotriene scores, so they were more inflamed, and I get that. I was really happy that our graph mimicked the trauma and burn patients from the glue grant. But then when I actually looked at the Resolvin scores, my CCI patient cohort had much higher Resolvin scores. And so to me, I couldn't really make heads or tails out of that. Are they having higher scores because they don't have the substrate and there might be some sort of feedback mechanism? So if I'm not feeding my CCI folks fish oil and EPA, DHA aren't around to be converted into SPMs, is the genetic makeup going to try and promote that and their genes are going to be expressed at a higher level? Maybe. Or maybe they just have higher scores because they're trying to overcome their higher inflammatory state. I just don't know. We're looking into that currently. So again, getting to a different area of interest, hot topic, the microbiome and how the gut bacteria can impact our health. Lots of studies coming out. And then what about this idea of like a pathobiome? And we'll talk about that. So Eli Metchnikoff in 1907 came up with this idea. So he was a zoologist. He was also an immunologist. He was the jack of all trades. If you look him up, I would highly recommend go to our favorite Wikipedia and look him up because he is very sophisticated. I do believe he was actually the person who actually identified and found the first macrophage. And so he was everything, but he postulated that a group of Bulgarian peasants who were living longer did so because of their consumption of sour yogurt. And so his idea was that the dependence of the intestinal microbes on food makes it possible to adopt measures to modify the flora in our bodies. And he thought maybe we can help promote our microbiome by eating good bacteria for us. The reason I put this picture up here, this is me and my partners at University of Florida. And so what actually happens to the microbiome during an ICU stay? Everything that I do as an intensivist ultimately changes the microflora of the GI tract. And I dare say it promotes a pathobiome. Unfortunately, because we are so good at sepsis and antibiotics and VAP bundles and all these different things that we have in our system, we end up promoting a pathobiome. And if you ever want to read about pathobiome, look up some of John Alverdi's work on what it takes. NPO, a dose of antibiotics, and a stress state, which is all my surgical patients. All of a sudden, you see, arginosis, Pseudomonas aeruginosus increase, and it starts expressing its virulent factors, which is certainly alarming. But these are the different things that I do to patients on a daily basis in the ICU that ultimately produces this pathobiome. And so how do probiotics work? There's competitive inhibition. There's actual physical barriers. Some probiotics can increase mucus production. They decrease adherence or attachment of virulent microbes. They outcompete them. Again, competitive inhibition up top. And then they also will adhere to the various selectin proteins on the mucus, on the mucosa, and will make sure that other virulent microbes can't bind there. They actually produce defense proteins and will secrete them to kill virulent microbes. They preserve tight junctions, and they also stimulate good host immune function, which is of utmost importance because you don't want an immunosuppressed state. And this is through the IgA mechanism that we have in our GI tract. Here's one of those examples that I wanted to share. So probiotics can actually help decrease peptic ulcer disease, and this is how we end up doing it. It has competitive inhibition and also attaches again to those selectin molecules. You have H. pylori attaches to the gastric cells. It binds there, and you get inflammation. You have decreased mucus production, and then all of a sudden you have peptic ulcer disease from a bacteria. Well, if you give Lactobacillus reuteri, it can actually bind to those same sites that the H. pylori does And now all of a sudden you have a decrease in the ability to render those inflammation cascades and cause peptic ulcer disease. They looked at this as a meta-analysis with probiotics, and the number needed to treat was 9. You got to be kidding me. That's unbelievable. Whenever you have a number needed to treat less than, double digits, triple digits, we're winning. All the other stuff that's listed under there that's not red, I don't know how that really kind of plays in. I never even heard of taste disturbances with peptic ulcer disease, but apparently probiotics help that too. The problem is that in most of these studies with probiotics, the probiotic strain is usually poorly defined, and the signal's all over the place. Is it going to be Lactobacillus reuteri, or is it going to be a different microbe? And we need better studies out there. Again, this is from Stephen Anton, and he looked at a meta-analysis and showed that when he looking at biomarkers for inflammation, IL-6 and CRP, what components actually decreased it in an aging patient population. They had to be over 65 years old, and what you can see here is that out of probiotics, here, let me go to the next slide. Here we go. So out of ARBs, omega-3 fatty acid, probiotics, vitamin D, we showed that the probiotic cohort actually had the most significant impact of inflammation resolution with probiotics. And that's incredible, because we should all be taking probiotics if that's true. We should all be taking fish oil and probiotics. I myself do that, and it still hurts when I stub my toe, but hopefully I'm a little bit healthier for it. So I'm going to go through some of the protein recommendations, as well as we're going to look at leucine and arginine again. I know Todd touched on that, and so we can very quickly go through some of that stuff. This man is Zudin Puccieri. He lives over in the United Kingdom, and this is a great study that he should certainly be proud of, because what he showed was that all these patients that came in, he took an ultrasound machine and he went around and started ultrasounding people's leg muscles. And so when somebody came in, he would be summoned, he would go up and do ultrasounds every day for, I think he said 2 weeks. And he was the only one who did it, because the last thing he wanted was to have a critique of the study be that there's too many people doing it, and he was his own essential control. And so he would be up there ultrasounding all these people that were sick in his ICU. And what he concluded was that the cross-sectional area of the rectus femoris decreased almost 20% by 10 days. 10 days, you had a 17% reduction in your cross-sectional area. The ratio of protein to DNA decreased almost 30%. So what that means is you have less anabolism, and you also have a decrease in the DNA needed to actually promote anabolism. And then 40% of patients showed myofibril necrosis, which is that little drawing down below where you see all that red. That's all inflammatory cells in the actual in between the muscles, causing myonecrosis. So muscle wasting occurred despite delivery of 0.7 grams per kilogram of protein. But now with newer recommendations, we actually start recommending higher doses of protein. And he admits that he probably should have been giving higher protein, but again, at least we have the literature that shows us muscle wasting occurs, and now we need to figure out what we're going to do about it. So this was the summary of the 2016 guidelines. Protein is the most important macronutrient. We could do weight-based equations to provide 1.2 to 2 grams. And if you're on CRRT, 2.5 grams, everybody pretty much knows that. But these are studies that came out after the cutoff of 2013, because they included all the studies from 2013 and then produced the 2016 guidelines. And this study in 2019 came from the Netherlands. It was a retrospective study where they collected data for 7 days over 455 ICU patients on different dosing of protein. And they used less than 0.8, 0.8 to 1.2, and greater than 1.2. And they actually showed that low protein, less than 0.8, fed prior to day 3. So day 1, 2, and 3, they got less than 0.8. Was associated with a 6-month mortality reduction compared to all the others. And they said that maybe timing might be better to increase our protein intake greater than 1.2 grams per kilogram per day after ICU day 5. And so I don't know if folks in this listening to this have heard Greet Vandenberg talk about autophagy, but autophagy is a mechanism that our cells can use damaged organelles from high stress states, because we have reactive oxygen species circulating throughout the body, and some of these intracellular organelles can get damaged, and what they end up doing is to clear and cleanse the cell. There's autophagosomes that will ultimately take that organelle or protein or receptor or whatever have you, break it down, digest it into its free amino acids, and then those amino acids can actually serve as fuel for the cells themselves and actually decrease the amount of catabolism. Well, the thing that turns autophagy off is protein. Greet Vandenberg's also known for her insulin studies, where she does tight glycemic control with insulin, and ironically, the other thing that turns off autophagy is insulin. So I don't know if she's has an internal struggle with that one, but I do think that this might have some key component to how we're going to be delivering nutrients to ICU patients in the future, because the largest signal for reduction in 6-month mortality, at least in this study from the Netherlands, was the patients that were fed less than 0.8 grams per kilogram per day for the first 3 days, and then 0.8 to 1.2 for days 4 and 5, and then over 1.2 after day 5 had the most significant reduction in 6-month mortality. Doig gave us this study, said that 2 grams did not hurt folks with renal dysfunction. And then coming from Australia, this patient included 119 patients with the primary outcome being hand grip strength. The actual amino acid delivery was 0.9 in the control and 1.1 in the study group. And so I do have a couple of points that I would probably argue. I don't know if 0.9 and 1.2 in that study is a big enough difference to actually see a significant primary outcome. But when you're using hand grip strength as your reporting outcome, I find that there are other clinical, probably clinical strategies that we can use or look at to study to have a more meaningful, a higher impact in our literature. Hand grip strength, for those of you that don't know, is correlated to functional state. So the higher your hand grip strength is, closer to your baseline, the more functional you would be. So you would have a lower Zubrod score. And some of the hand grip strength literature actually suggests that there might even be a mortality length that people with higher hand grip strength might have a survival benefit. But when you're looking at hand grip strength as a primary outcome for nutrition, I start questioning that a little bit. And then Michelle Nicolo from Penn with Charlene Confer looked at 2,800 patients at day 4 and 1,600 patients at day 12 in a multicenter observational study, and they suggested that greater than 80% gold protein may have a mortality benefit at day 4 and day 12, and they have a quicker time to discharge alive from the hospital. Again, another study from Charlene Confer and Dr. Halen. 2017 is a prospective observational study. This is the study on that last page, and what they showed in the high-risk Nutrix score greater than 5 patients had the higher benefit. We've seen studies like this come out time and time again, that the more at risk for malnutrition you are, the more impact nutritional strategies will have for you. And then we showed that early high protein intake is associated with lower mortality, and you could see that there. And then early energy overfeeding is actually associated with higher mortality. So it's not just giving people protein, you also got to make sure that you don't overfeed them. And I think overfeeding with carbohydrates is probably the worst for a ICU patient. And so we got to be cognizant not to overfeed patients, which is, in the first week of critical illness, going much higher than 80% of your calories could be detrimental, but you should still adhere to that high protein diet. A lot of these different discussions for protein are found here, and it's a great paper that I know a lot of folks worked really hard on this. And if you ever need to kind of reassure your protein delivery strategies and what you would like to do, I would recommend reading this. So now looking at a little bit of the immunonutrition side that Todd had discussed. Arginine, again, is conditional amino acid deficient in stress states and required for proper immune function and wound healing, as well as everything else that Todd had discussed. But there is a controversy over it, and that controversy largely lies in whether or not arginine is going to be shunted down into the nitric oxide pathway and potentially cause vasodilatation in somebody who's in sepsis, potentially convert somebody who's severe sepsis to septic shock, or make somebody refractory to pressors, which I don't think when you look at the literature, that's all speculation. There's not a study, to my understanding, that has shown and demonstrated that. But sometimes, you don't need studies for common sense reasons. I still don't think arginine is going to hurt somebody in sepsis. But the way that I use arginine in my practice, again, are for the chronically critically ill folks, the PICS patients, where we've already had source control, they got ongoing organ dysfunction, and they're off of pressors at that point. So arginine deficiency comes in a multitude of different ways. And again, the T cell dysfunction, the biggest one is this right here. Decreased T cell receptor, because you lose the zeta chain. Your T cells no longer are able to look at an antigen, accept it, and generate any kind of immune response to it, because the T cell receptor is dysfunctional at that point. And so what ends up coming down the pipeline is you have energy to recall the antigens during an immunosuppressed state. Leucine is really interesting because leucine hits the mammalian target on rapamycin, the mTOR pathway, to promote anabolic growth and decrease catabolism through hypertrophy of muscle and decrease autophagy of protein breakdown. The mTOR response, there's two different mTORs. mTOR1 is what most people probably talk about when they talk about this, but it also needs arginine with leucine in order to have this anabolic response to decrease catabolism. During the severe septic state, when you come in sepsis, septic shock, mTOR pathway is actually downregulated. So it's very hard to promote anabolism in a septic patient. Safe to say, when they hit that chronic critical ill state, PIC state, we're trying our hardest to start getting good muscle mass back on these patients. So in summary, is gold standard evidence-based nutrition good enough for these chronic critical ill patients? And I don't think so. I think we could do better. We got to come up with different strategies. There's this idea of not only coming up with an anti-inflammatory diet, but there's people out there that talk about, even if it's not anti-inflammatory, it's got to be anti-catabolic. And so we got to be able to hit inflammation to decrease the amount of catabolism, or we got to just go straight for catabolism out the gate and see if we can't keep these patients with good lean muscle mass on them to keep them functional or a higher functional state at discharge. Can we utilize other nutrients as individualized targeted therapies to help promote anabolism and reduce inflammation? And I do think the overwhelming answer there is absolutely, as we have seen. And again, here's that diagram that I was showing you at the very beginning. I do think that over time, what we'll find is that omega-3 fatty acids and resolvins and probiotics are going to help play a huge factor into decreasing some of the inflammatory state. And if we could decrease this inflammation, get them closer to homeostasis, decrease the inflammatory cytokine milieu, you'll see that this catabolism, or this state where they are resistant to our nutritional therapies in promoting anabolism, will start decreasing. With that, I was going to finish up the case report, which, our 22-year-old female ultimately had a prolonged clinical course. She was able to tolerate her tube feeds. It was felt, though, that we did not want to go ahead and let her start eating, though she was 100% neurologically with it. She had what we call an 8.0 tracheostomy in, and an 8.0 with a cuff on it is pretty robust in your airway and sometimes can inhibit the swallowing mechanisms, as well as, when you have somebody that was almost cannulated for ECMO, the risk and benefit of her potentially aspirating was felt to be very high. If she accidentally had, even a silent aspiration that triggered an inflammatory response again in her lungs, she wasn't going to do well. So she was discharged with her 8.0 in, and she went to an LTAC for a vent wean. Ultimately, she did suffer considerable catabolism, but she was decannulated, and she got a swallow study and passed and was allowed to eat. She was happy. She went to a rehab after the LTAC, and I believe she's home now and alive. The only reason that she made it is because she was 22 years old. If this happened to somebody of advanced age, there's no way this would have ended well for that patient, especially with COVID-19. And so I do appreciate everybody listening today. With that, I am happy to take any questions, and thanks for your attention.
That was an excellent presentation. Thank you so much, Dr. Rosenthal. So as Dr. Rosenthal mentioned, we will now take some questions, and we already have a few. So first question, considering the pleiotropic effects of probiotics that you summarized, do you provide all of your patients in the ICU with a probiotic?
Excellent question. Our probiotic that we have on formulary is Culturelle, and the Culturelle that we have is, well, I mean, it's on the shelves anywhere, is low concentration of probiotics. It's only one colony. So to answer the question, I try to. I actually came up with my own probiotic protocol, and we were about to bring in a spore-based probiotic. Had 3 billion colonies of 4 different spores in it. And the reason I like spores is because the spore can shed some of the, not shed, it can survive some of the acidic environment in the stomach. So during first pass, about 90% of your probiotics die in the stomach because of the high acidity, and they don't render any kind of benefit until they actually reach the colon. And so if you can imagine why C. diff is so effective in doing what it does, it's because C. diff is a spore. And I think, the idea, the notion of fighting spores with spores really kind of caught my attention. Unfortunately, it's an act of Congress in order to get anything on formulary at University of Florida. And I had to go talk to there was a C. diff task force, there was the infectious disease task force, there was P&T committee, there was all these different hurdles, and I finally got everybody to agree, and we were going to bring it on. And then somebody said, well, why don't we study it? And so everybody threw up their arms. We had to undergo this entire IRB process, and eventually I think it withered out, and I lost steam because it was such a long haul to try and get it on there. But Culturelle, I think the message for any probiotic is you want high colony forming units in the verge of billions, and you want a diversity. You don't want to just adhere to one product. Myself, I drink kefir. I will take some kombucha. I have my pills that I take. I try and find any type of source of probiotic just to keep it all diversified down there and not just on one product. I hope that answers your question.
Thank you. I appreciate that answer. I have additional questions. Are you aware of any data that shows SPMs have the ability to inactivate enveloped viruses such as SARS-CoV-2?
There is data. Let me think. So I want to say there was something. I want to say they studied it in uveitis, an ophthalmology disease process that it decreased viral infections causing eye issues. I'd have to find that for you and get it to you. But there are studies that show that SPMs will promote healthier individuals and decrease the inflammatory response. And so I would think that we can, make inferences from that literature as far as its impact into viruses. I do like the idea of using SPMs in COVID-19. I really do, but there is no literature on that right now.
Wonderful. Have you ever looked at patients who went to rehab or home post-trauma or hospitalization on some form of nutrition support versus oral intake alone to determine if having longer-term parenteral or enteral nutrition support positively impacted outcomes or mortality survival rates?
No, I have not. We do, so that is something that we can do. We have follow-up in our P50 through 3 years. So I could pull that data, and that's an excellent question. Whoever asked that question, if they're still listening, email me that question, and I'll see what I can do as far as pulling some data and looking at that.
Great. Okay, I have one last question. Regarding the CCI versus RAP patients, was there a control for or tracking of differences in physical therapy provided to the patients while in the ICU?
There was no control, I guess would be the answer. Everybody in our ICU gets physical therapy that is extubated. So I don't know how to really answer that question.
Okay. Well, that is, those are all the questions that have come in. Once again, thank you so much, Dr. Rosenthal. And thank you to the audience. Should you have additional questions, please feel free to submit them to Gaspen's email, which again is gaspenga@gmail.com. Okay, so now we will take a break from our accredited